All right, I think we'll make a start. Hi everyone. So this is our first, oh, 1 second. Yeah. So this is our first lecture as part of the careers series for Mind the Bleed. And we've got Dr. Adrian, who was very kindly going to give us a webinar on anesthetics, ACCS anesthetics as a pathway, a bit about the interview preparation and other general advice. There'll also be the chance to ask questions throughout. We'll answer them at the end. And you can get these slides afterwards if you fill in a feedback form and provide your email address as well as a certificate. So what I'll do, I'll let Dr. Adrian make a start, and it should be roughly, I think, just under an hour or so. So take it away, Dr. Adrian.
Hi, thanks very much. Hello everyone, thanks for joining us today. So yeah, my name is Adrian. I'm a ACCS Anaesthetics CT1, which is always a bit of a mouthful, and I'll be taking you through a bit about the specialty as well as the application process and some tips for portfolio and interview as well. It is quite jam-packed, so I'll be aiming to finish in about 40-45 minutes, and then please, any questions that you have, let us know. We'll try and get around to answering them towards the end, and if you want to email me, there's my email address at the bottom of the screen as well, so please feel free. So there we go. So a bit about me. So now IB graduate, then I did an undergrad in physiology at UCL. Didn't get into med school first time, so I did a first degree, graduated medicine 2019, also UCL, and then I did a pretty standard set of F1, F2. The only interesting part was redeployment to ITU, so I did go to ITU during COVID, the first week for about 6 weeks, but aside from that, it's pretty much your standard surgery, gen med, obs and gynae, psych, and then more general medicine. And whilst an F2, I applied for ACCS anaesthetics training and got my first choice deanery, which is Yorkshire. What to expect? I've just popped up the feedback QR code, so feel free to sort of use that, give the feedback, and like we said, we'll send you the slides at the end of the talk once you've filled in the feedback form. So firstly, very important, this is aimed at CT1 applicants. Anesthetics and ACCS anesthetics are not run through, so you do unfortunately have to apply a second time, and these will be the bits that we'll be covering today. Resources, anesthetics is a specialty, shape of training, application process, portfolio, and the interview. So resources, I've just listed here sort of your absolutely necessary to go through. Absolutely have a look at the Royal College of Anaesthetists website. Lots and lots of really good information about the specialty, about the syllabus, the new curriculum. You can become a member for £3 a month, which is like nothing. Loads and loads of events. Association of Anaesthetists, again, lots of how to get involved, resources, publications, webinars, the GAP handbook, so guidance for anaesthetists in training is super helpful. The ANRO, which you will get to know very well if you do put in an application to the Anaesthetics National Recruitment Office. Really, again, lots of useful information. And then specifically information about the acute care common STEM. And I'll explain a little bit more about this because it does come in 3 different flavors and there's a lot of misunderstanding around how it actually works in practice. Again, these are just resources I use. I'm not affiliated with any of them, but find them very useful. Anesthetics interviews, the first one, do some fantastic courses on around the interview, the application process. Anesthetics interview, unhelpfully, they have pretty identical names. They do a fantastic question bank, which I really recommend. The ISC medical interviews book, which is again sort of your bread and butter if you're going for interviews. And then finally, MSRA. I used PASS-Test and PassMed, but you've got a few different ones. MCQ Bank, I think, is the one that people most often say is the most useful one for the MSRA. And again, foundation doctors, I know we might have some foundation doctors as well as medical students listening in, but foundation doctors, you can sometimes get funding towards aspirational activities. So these courses that you would have to pay for out of pocket, like in my deanery, I was able to get actually funding towards them, so worth asking. So anesthetics as a specialty. what are your key responsibilities? Well, peri and post-operative care, pre-assessment clinics. There's not very much clinic time, which I find quite good because I'm not really keen on clinic. Resuscitation and arrest call. So as you probably know, there's always an anaesthetist who comes to any arrest call in the hospital. You have a big role in obstetric anesthesia, so you all have to rotate through obstetrics. Support on ICU, pain medicine, transport of acutely ill injured patients. So there's now sort of a pre-hospital branch as well, which is kind of pioneered by anaesthetists. So if you think about your HEMS and things like mountain rescue and events-based stuff as well, there's a lot of pre-hospital opportunities in anaesthetics as well. Wider roles, so education management, research, quality improvement. Anaesthetists quite often are in a position, because they spend a lot of time in theatre when sort of things are sort of just progressing as they should, so they have time to engage with other sides and other roles and other responsibilities. And it is worth pointing out that anaesthetics is the single largest hospital specialty. So that I found quite interesting. I didn't know. I think only GPs technically are a bigger specialty than anaesthetics. What sort of person should you maybe be if you wanted to apply and enjoy anaesthetics? So definitely liking core medical science is really good. So if you like your anatomy, physiology, pharmacology, if you enjoy procedures and sort of the manual dexterity that comes with it, working well as part of a team, so stressful environments, sometimes theatres or arrest calls, so equally coping under pressure. Generally, anaesthetists is very much involved with learning, teaching, simulation, that side of things. Having to be quite meticulous is always a good thing, a good trait to have. If you like dealing with sort of one thing at a time, one patient at a time, that's also quite good. If you don't want to spend too much time in clinic, but equally don't mind a longer ward round, like ICU quite often has long ward rounds, and if you can function quite well as quite a proactive member of a hierarchy that is reasonably flat, but then when things do happen, then someone will very obviously rise out of that hierarchy and take leadership in a situation, and then it will sort of settles back down. Lots of one-on-one supervision, so it's a very well supported specialty. Shape of training. So again, if you have any medical students listening in, it's more for you guys. So remember, medical student, you progress onto foundation training, and then you might take it out. You might also do medical school, do an additional degree, and then you progress into specialty training. And then some specialties have an exit exam. Anaesthetics doesn't actually, so we'll come on to the exams a little bit later, but there is no exit exam. And then finally, sort of CCT, which means completion of training to either a GP or consultant in this case. Anaesthetics training is divided into 3 stages. So this is with the new curriculum. So sometimes you might still see that you do CT1, CT2, and then you progress on to the next stage. So that was the previous curriculum, which has literally changed just now in 2021. And the reason being that quite often, suddenly very young CT3 doctors would be left alone sort of on labour ward for a night shift, and that was quite terrifying. So they've decided to actually extend that first stage of training. So it's just been restructured. It's not, the overall training is still 7 years for single specialty anaesthetics, but that first stage has gone from 2 years to 3 years, and then stage 2 would be your SC4, SC5, and then stage 3 would be sort of that preparation for CCT, so preparation for becoming consultant. You can have a look at the curriculum in your own time. I've put the link at the bottom, and like I say, we'll be sending out the slides, so you can all the references I've put in, you'll be able to look up for yourself. Difference between core anaesthetics, CAT, and ACCS anaesthetics, which is what I'm doing. So ACCS is acute care common stem, and it comes in 3 flavors, which is anaesthetics, emergency medicine, and internal medicine. And basically that denotes your parent specialty. So it's not like you apply for ACCS and it's all 3 in the same one and then you branch out. You apply for ACCS alongside with its parent specialty. So like when I applied for anaesthetics, it was not possible to apply for anaesthetics and ACCS anaesthetics separately. When you get these sub-preferencing for jobs, you literally get the list for all ACCS anaesthetics and all core anaesthetic jobs. And obviously you can decide not to preference one or other type of job, but you literally get everything on that preferencing. What ACCS does do is, regardless of your parent specialty, you rotate through 6 months of emergency medicine, 6 months of acute medicine, 6 months ITU, and 6 months anaesthetics in your first 2 years. So everybody does that, and then you branch off according to your parent specialties. So if you're wanting to do anaesthetics or AnaestheticsACCS, then those would be your possible outcome. You could do anaesthetics alone, you could do ICM, so that's kind of what you can do if you've come up an ACCS background and you're wanting to dual train in anaesthetics and ICM, which is my reasoning, for example, for wanting to do ACCS, is because you get those additional medical rotations that you need. That is a requirement when you apply for ICM at registrar stage. Or actually you can do pure ICM as well, which is becoming its own pathway, but quite often you still come off an ACCS background and go into ICM. So just be very, very careful what you apply for. Really, if you're applying for anaesthetics or ACCS anaesthetics, your home parent specialty will be anaesthetics. So ask yourself that question: do I want to do anaesthetics as my parent specialty? Intensive care, so I'm not going to go into too much detail on this. Again, I've put in the relevant references for the curriculum and also for the ICM National Recruitment Office, but this would be roughly a specialty training pathway. You would do, for example, your ACCS, which is not 3 years now, it's 4 years, and this is a bit of an outdated diagram. You would then transition into your specialty training, and then you would sit an ICM specific exam. You can dual train, like I already mentioned. So for example, with anaesthetics, with EM, or with IM. So those are your 3 options for dual training. And yes, there's always someone who asks, can you triple train? As in, can you have anaesthetics, ICM, and medicine? And yes, you can. I'm not going to go into detail on that. You can look that up, but yes, it is now possible. So triple training is recently become a possibility as well. Exams. So if you're doing core anaesthetics, you said the FRCA primary, so that will be in either CT3 if you're a core training, or CT4 if you're an ACCS training. Just to make that very clear. So in core, if you're a core trainee, your stage 1 is 3 years. If you're an ACCS trainee, it's 4 years. So you essentially do like a 0 year. Your first year is additional medicine, and then you sit your FRCA final, which is which allows you progression beyond your ST5 year. If you're dual training with for ICM, then you have to sit your ICM FFICM, that will be your later day exam, along with whatever your primary background was. So those are your 3 options for primary examinations. It's either going to be the FRCA primary, and then FRCA final and FFICM, or is going to be MRCP and then FFICM, or then it's going to be MRCEM, so that's your emergency medicine, plus your FFICM. So those are kind of how the exams work. If you're just doing core anaesthetics, it's just going to be your FRCAs, your primary, and your final, and that's it. Application process at CT1. So it's a national recruitment. So you apply in first. So the first bit of preferencing you do is either you apply to England and Wales, or Scotland, or Northern Ireland. So you have to make that decision from sort of right from the beginning when you submit your oral application. That's oral is a platform that you use, so similar to when you were applying for foundation. There's 2 cycles each year. There is an August intake, which is the big one, and there's a February intake, which is a smaller one. Essentially, it happens in 2 stages. So you have long listing, which is where you've submitted your oral application, and then they say, great, that's fine. Please go and sit your MSRA. And then the shortlisting is when you've set your MSRA, you have the score, and then based on that, they decide whether or not to invite you for an interview. MSRA works with a cutoff. So the last year's August intake cutoff was 525 on the MSRA, but it also contributes 15% of the overall candidate score. And then the interview is 85% of the overall candidate score, half an hour interview, of which 15 minutes now is a portfolio session and 15 minutes is a clinical scenario session. So the interview has massively changed. So pre-COVID, it was an hour. In person, you have three stations, 20 minutes each. Then COVID came, then they sort of changed it to be actually my cycle when we set it was 10 minutes for portfolio and 20 minutes sort of general interest, kind of general motivation questions. And now they've gone and changed it again. So they're giving 15 minutes for a portfolio station and 15 minutes for a clinical scenario station. And like I mentioned, sub-preferencing, so you will have access to all anesthetics core and ACCS anesthetics jobs. This is literally just a screenshot of ANRO. Like I said, the Anaesthetics National Recruitment Office. Really recommend visiting it. It's got like all of the information you could want for your CT1 application, person specification, guidance, MSRA guidance, anything and everything. So please get very familiar with it when you're applying. And rough timeline. So closing day, that is your submission for oral. Please do not miss this. If you miss it, you just have to apply in the next cycle. Like you can't appeal that. MSRA window. So you have about just over a week, I think, about 10-day window in which you can sit it. So it's a bit like you go to a Pearson View Centre. So those of you who still remember the UCAT, it's a bit like that. And then again, invitations for interview and applicant declaration is an important day. So invitations to interview, the late dates, I'll come on to this, fly off the shelf. So the day that you know that interview invites come out, like literally sit on your laptop, because if you don't and you leave it till later, you'll only have like the earliest slots available, and usually that's only about a week after the invites go out. So be quite proactive, I would say, on the day. And then whole deadline. So if you get offered a post, then obviously congratulations, you have three options. You can either decline it, you can accept it with upgrades, or you can just accept as is. So that's like you wouldn't get upgraded if you just accept it as is. Oral, mostly a tick box exercise. So for anesthetics, you might hear about other specialties, like I think pediatrics, they have like white space questions and evidence submission and whatnot. Again, sort of the information that we have at the moment is that there are no white space questions, no evidence submission, but be very careful about a few things, particularly employment history. So you literally have to list all of your rotations with dates. And if you're coming straight out of F2 because you need a 3-year employment history, you also have to put in your final year at medical school, so it's a bit weird. But please check these days. I literally know someone who just, because of a typo, they were automatically rejected because they just simply, it appeared as though they had like a month's gap in their employment and they didn't, it was just a typo and they couldn't appeal it. So be very careful. 3 references you'll have to have. So this is typically going to be your ACCS and another CS. I think I put in my ES and then 2 consultant anaesthetists I've worked with on COVID ITU, just because I knew them well and I had a good rapport with them, but let them know that they're going to be contacted for reference. And then this is the only bit of like evidence, they call it evidence, but you're not submitting any evidence. It's just like there is a section, and I'll show you the I've got like screenshots of my PDF printout of actually my Warrior application. So you can put in additional undergraduate degrees, qualifications. If you've got BSc, IBSc, that would go under there. Postgraduate degrees. So again, if you've done PhD, MD, whatever. Masters. Anyway, achievements. So if you've got prizes, awards, distinctions from med school or otherwise, and then training courses, and you can put in up to 6, and they do advise you to include, you have to include your ARS as well in there. So this is what my employment history would have looked like. So these are literally all of my rotations from my foundation years with all of the dates put in. So these are the dates that you check. This was my additional undergraduate degree. So I put in my physiology degree. I had no postgraduate degrees and qualifications, and I had won no prizes. So that was blank, which is fine. And then I put in my training courses, and then these were the 6 that I had. So you're allowed up to 6. So ALS, taster weeks, if you do them, please do them, put them in. A career in anesthesia. So this is Royal College event that, like, if you attend anything sort of Royal College, you put it in. Taste days, put them in. Hub days, put them in. And then I'd done like a trainer type course as well, so put that in as well. But that's just an example list. The MSRA, so this is multi-specialty recruitment assessment. It was initially used in GP selection, but now most specialties use it. So anaesthetics started using it because of COVID, because they had to, up until then, they would literally interview everyone, and it would be about quite strictly how your portfolio scored and how you performed in the interview. But they needed essentially a way to cut down the number of people they're interviewing. It's still quite generous. I think they still interview like 2/3 of applicants, so it's not terrible, but don't underestimate it. It is go through your sort of SJT notes that you might have from medical school, because there is the professional dynamics and SJT-B. And again, for those of you who did finals, who did the SJT in the UK, this is a familiar pick 3 out of 8 and then rank 5 type questions. And then clinical problem solving, essentially this is SBAs and EMQ style, kind of like finals over again, but with sort of a bit more clinical relevance. So it is appropriate to the level of an F2, I would say. Don't underestimate specialties that you haven't necessarily worked in. So I know that I struggled with like PEDS questions because I didn't do a rotation in PEDS. So that was something that I had to sort of go back and focus a bit more on. But it's pretty straightforward, and get a question bank, work through it. It's nothing too terrible. How competitive is it? Well, depends what you compare it against. Amongst the biggest specialties, like the main specialties, probably a bit more on the competitive side. Definitely last year saw a record number of applicants, probably because actually COVID redeployments made it more possible for F1s, F2s to engage with the specialty, and actually a lot of junior doctors sort of had more exposure and found it quite interesting. So all I say is you don't have to be exceptional. I was definitely not exceptional. You just have to be prepared, sort of go through the motions. It does take a lot of time, I will say, like when you're doing F2 and suddenly like you're having to settle into F2, but then also you're having to do a lot of like prep for MSRA and whatnot. So just be prepared. Like that's the thing. Portfolio at CT1 level. So all money, you had, like I mentioned, a self-assessment and very stringent evidencing. So it was a very strict points-based system. And then COVID hit, and actually it made because obviously interviews stopped happening face-to-face. So it wasn't like you rolled up to interview and you brought this massive folder with all your evidence and you showed it, and then they went through it and said whether or not they agree with your self-score. It became practically impossible to do that. So they've said, right, let's forget about that. Let's leave the self-assessment and we'll just put out person specification, which they actually already had, and we'll just go with that. Now I'm going to show you the person specification. I don't find it necessarily particularly helpful in knowing how to be a better applicant, or how to, like, what could be the things that you could do to maybe score better in a certain section. So if I were alone in the world, I would say use the self-assessment from 2020. It's not officially the thing to do anymore. Would you be at a disadvantage if you didn't use it? You shouldn't be, but I would still really, really recommend that you have a look and you look at what would have scored higher, and you go in having looked at it and relying on it, not so much, like don't worry too much about the points, but just use it as general guidance on top of the applicant person specification. Again, I've put all the links in. How early should you start preparing your portfolio? Well, as early as you like, really. If you're a med student, think about doing your elective in anaesthetics if you're interested. That's what I did, doing SSE in anaesthetics, which is what I did. I knew quite early on. I was quite lucky in that I just knew what specialty I wanted to do. But be strategic. So always weigh up how much time you're investing against a certain outcome. Be realistic. So can you achieve this goal? Be proactive. So literally, unfortunately, it's just a bit like you have to approach people. You have to sort of put yourself out there a little bit. Talk to your Royal College of Anaesthetists tutor. So most trusts will have one, or just get to know anaesthetists around your trust. So literally, I had a consultant anaesthetist who helped me prepare for my interviews, and she was fantastic. And the reason I got to know her is because when I was doing my obs and gynae rotation, I handed over a patient to her and I discussed the patient with her, and I kind of went like, oh, by the way, I'm applying. And she was like, oh yeah, great, like I'll do interview prep with you. And yeah, she was fantastic. So yeah, just put yourself out there. And finally, it is never a bad idea to keep evidencing, like if you go, courses, get your certificates, save them somewhere, because again, based on what we currently know, when you apply for your registrar jobs, you will need to evidence so there the portfolio physical evidencing will be important, and basically along with that, keep your CV up to date as well. It really helps. The first thing I did actually when I started prepping my application, even before I touched oral, I just really went through my CV and sort of had it essentially like arranged the same way as I did my portfolio, and it really helped to be like, oh yeah, I did that and I did that and I did that. That's actually quite helpful. It just helps you sort of navigate through the clutter. So this is the current guidance, like it says, the person specification. So some of it is quite straightforward, sort of your additional degrees, fine, and then aptitude for practical skills, fine, clinical skills wise, academic skills, research. So it's, I'll leave you to have a look at it in your own time, but it's literally like 5 pages and that's it. And there isn't really any more guidance out there unless you pick up that 2020 self-assessment. Obviously probity, commitment, specialty. So it's got like all of the very obvious stuff. Now, if on top of that you were to look at the self-assessment, you would find that it was very much, like I say, very much a point-based system, and it was very much sort of gunning for as many points as you possibly can. And I've put in here just the oral sign to indicate that currently you can, these are the bits, these would be the bits like undergraduate training, additional degrees, you would be able to list that on oral in that section about evidencing, like I mentioned. Same with your prizes and awards, you would be able to mention those. Same with your postgrad medical qualifications. And also if you have any sort of additional rotations beyond F2, if you're taking an F3 or an F4 year, then obviously you would list that again under your employment history. So you can see that at this point, like I was coming straight out of F2, so in again old night I would have been scoring 0 points on this. Currently it doesn't really matter. So in my interview they asked me, what were your other rotations, and I told them same information as I've given on oral. What I will really urge you to be cautious about, and this is a bit of a weird thing with a lot of specialties, same with surgical specialty actually, is that if you exceed 24 months employment in related specialties going beyond your F2 year, you actually become ineligible to apply. So be very careful. So if you're sort of approaching that F4 year and you're thinking of applying, just be very careful, because if you spend 24 months in related specialties like acute medicine or A&E or anything like that, even if you're sort of just locuming, you actually become ineligible to apply. So be careful. Commitment to specialty. So again, you can, these would be things like your courses. So for most students out there, think about your optional modules, like I mentioned, your SSCs, your electives. And again, I'm just quickly going to touch on the courses attended. So again, you don't get any points for it as such because it doesn't exist as a points-based system, but they do ask you, they in your interview, you can and you should say about any relevant courses that you attended. And a lot of the times people think about the big ones like ATLS Basic, Impact, these ones, because those were the ones that got listed, like you can see them listed here as well. And it doesn't have to be like that. Like you can literally, I would say, go for the low-hanging fruit. So go attend the virtual career in anesthesia event at the Royal College. It's like commitment to specialty. I went to a taste, like virtual taste things, everything these days, everything's virtual. Attend like Royal College events, again, like literally they're really cheap, they're like maybe £30, and you just listen in on it like you would sort of on a podcast. And again, it's like commitment to specialty. I went to this event, I thought it was these are some really interesting points that they raised. And I'm going to just mention A-line anesthesia as well. So A-line is anesthesia learning in the Northeast, and they do amazing events, and a lot of them are free of charge. So they did this massive conference leveling field on championing diversity in the NHS. So again, that's like just a really great event to be able to mention into. Clinical governance, audit, quality improvement. So again, for any math students out there, talk to your local MedSocs for opportunities, action module leads, placement leads. Think about your planning your SSC and elective, and including audit or QI in there. As for F1s, F2s, unfortunately, it's just an unavoidable part of the portfolio. So plan early. So I did a obstetric anesthesia related QI project early on in my F2. So I found a friendly anaesthetist, and I was able to do that project with them, literally kind of still in time to be able to talk about it at the interview. So think about if you set up early, then obviously you have time to complete a cycle. And that's again something that in the interview they ask very specifically. What project did you do? Did you design it? And did you complete a cycle on it? So again, in terms of the wording, it's quite similar to the self-assessment. Research, again, think about math students, get a vacationship. That's always really good, looks really good on your CV. IBSC years, elective SSC, student conferences. If there isn't one being run at your uni, set one up. It's great, like literally set up national student conference, which is really good. And then for foundations, have a look on the Association of Anaesthetists website. Again, have a look locally what trainee conferences get advertised. You can always liaise with sort of your Royal College tutor as well. And obviously there is an element that if you've gone and done a research degree, you're a bit more of a mature applicant, you might have a bit more to talk about, but like, it's just what it is. Some people will have more experience and some people will have less. It's just what you make of it. Teaching, again, it used to be very much sort of focused around formal teaching, like have you set up a teaching program, and then it was very specific. In my interview, I was asked what teaching I had delivered in what formats, and then I was asked what type. They asked what are sort of the what's good and bad about different types of teaching. What different types of teachings do you know? Teaching styles do you know? And what's good and bad about each of those? And how do you find that you learn the best? So it was a bit more loose. It wasn't quite so stringent as how many sessions, with whom, over what period of time, like it would have been again. So that's why I'm saying don't get too obsessed about the points. Just use it as a bit of a guidance, because it's quite helpful. Publications, again, can be time consuming, so weigh up if there is a more strategic way for you to spend your time and have something to talk about. Obviously, if you do have a publication, great, absolutely do talk about it, do mention it. Presentation, poster presentation, so again, it should be reasonably easy if you do a bit of research, if you do a bit of a student vacationship, if you're still a student, if you do a bit of QI, just to get a poster sort of submitted either to like a student conference or like a foundation trainee conference. It's not that difficult, and again, that's quite good if you've had a poster presentation. Like usually conferences are at least national level. And then activities outside. So again, if you're sort of volunteering, committee positions, student foundations, so again, you can always use these to illustrate various skills and like team working, and leadership and commitment, and so on and so forth. So that's always good to have. Right. I've put a bit of a list in here. Is by no means exhaustive, but just a few ideas where you can look around for sort of career building opportunities. So there's the HLA Medics Academy in med schools who I'm with actually. So I'm the Director of Academia for Med School, which is a big national outreach program trying to get kids from underrepresented backgrounds into med school. So if anyone's interested in the role of a BMAT officer, please let me know. I am officially recruiting for a BMAT officer if you're interested. So that's my little ad, just very quickly. And then the MJ students, or again, definitely for the med students out there, good to know about. Right, on to the interview. So CT1 applicants. Again, this is what the ANRO website looks like. So this gives you a list of the different deaneries and when they interview. Now, importantly, like I said, you have to specify if you're applying to England and Wales, Scotland, or Northern Ireland. If you're applying to England, it doesn't matter which deanery you book with, okay? So like I'm a Yorkshire trainee now, and Yorkshire was my first choice, but I think I interviewed with West Midlands, I want to say. I don't even remember. So basically, if you apply to Scotland, you have to be interviewed by Scotland. If you apply to Northern Ireland, you have to be interviewed by Northern Ireland. If you apply England and Wales, it doesn't matter. So don't get panicked. They still break it down as they would have when interviews were face-to-face, and you would actually have to interview with the deanery where you were applying, but that's not the case anymore. So please don't panic. It just tells you which deaneries run their interviews when, but it really doesn't matter. And like I said, the day you know that interview invites are opening up, literally, kid you not, sit on your laptop. So that's what I did. I just sat on my laptop, and the moment they opened it up, I went and booked immediately. And the later dates absolutely fly off the shelves. Now, if you're not too fast and you're happy to prep within a week, that's, you know, or if you've already been doing prep, that's fine. But literally, if you get an earlier date, like you might just have like the week to prep for it. So I would definitely recommend trying to get a later date. Domains and the scoring matrix. So this is what it looks like at the moment. So it's a virtual interview. You have 2 panel members and then like a third person who's just like observing. So you'll have an observer as well. They don't score you, they just sort of observe. And these are literally your domains that you get tested on, or well, assessed on. So commitments, specialty, decision making, involving teaching, audit, QI, research, reflective practice, team working, qualifications, experience working under pressure. So you can see how some of those would be more obviously portfolio type questions, and some of it would come under your clinical scenario part of your interview. So again, this is straight from ANRO. On the previous slide, that's if you click on each of those, you go into ANRO, you click on each of those, it will give you these rubrics, which I use and found them again really useful, because it tells you like the different, how do you progress from a score of 3 to score of 5. So what would be the things that you would have to pay attention to? What would you have to point out? So first off, with qualifications and experience. So this is literally they ask you pretty much first question is, so what are your qualifications? What's your experience? So go through university education with appropriate relevant SSC elective, F1, F2 rotations with appropriate relevant taster days, prizes that you got in any of your rotations at medical school or during foundation, posters, presentations, publications. So literally think about this as sort of almost like bullet point going through your CV. Teaching, audit, QI, research, I literally gave that, at least in my portfolio session, it was very, very time pressured, and they literally give it to you as one question of like, tell me about your teaching, audit, QI, research. So it's sort of you're trying to reel off an answer really, really quickly. But do you know your definition of a QI and audit? Because they did put that a little bit of, you know, what's an audit cycle, what's a QI loop, be able to, like I said, talk about different styles of teaching, what's good, what's bad, what teaching style you've used or you've benefited from and why. And describe the different stages of research as well, and know the difference between research and the QI is quite handy. Commitment to specialty, so why anesthetics? So I'll come on to the structures in a bit, but use your CAMP here. So CAMP stands for clinical, academic, management, so soft skills, and personal reasons to wanting to do anesthetics. They will 100% ask you why you want to do anesthetics, and also they will ask you about the shape of training. So they said to me, like, so as you know, the curriculum has changed in 2021. What do you understand by these changes, and how do you think this will impact your training? Something along those lines. And I was like, well, let me tell you, because I've gone and read about it on the Royal College website. Literally, there is like a half-hour lecture on it, and you go like, great, now I know. So it's literally just go and have a listen to that. Read the GAT handbook, like I said, so the guidance for anaesthetists in training, super, super, super helpful. Assessment tools, so again, know a bit about, like, again, that lecture that I mentioned goes through EPAs being entrustable professional activities. Responsibilities of being a proactive trainee, and sort of the idea that with the new curriculum, there's more integration with sister specialties of like acute medicine, emergency medicine, and ICM. Clinical judgment, decision making. So again, go through these. practice your sim style scenarios. So if you've got access to sim, so OMS, I think Oxford Medical Sim, you can do stations with them. Revise your emergency. So I definitely went through sort of at the back of cheese and onion. You have, or Oxford Handbook, you have your medical emergencies. Go through them. Know your sort of basic doses for diazepam, bits like that. Practice OSCE style, really quite helpful, just to put you in that mindset. Be safe, call for help, the usual. If in doubt, ABCD, and just keep reassessing. SBAR, so they might ask you for a handover at the end of the station, so just use a good solid SBAR to handover. And like I mentioned, anaesthetic interview, they do, well, as far as I know, the only question bank actually that includes clinical scenario questions as well, and they've got quite a few stations, so really worthwhile. I would say a subscription to those guys and going through their stations. In addition, I will point out to know what a serious incident is. So I got asked, were you ever involved in a serious incident? I hadn't, but and they then asked me, what do you understand by a serious incident? So again, have a look at that definition and just know it. Similar with duty of candor. So if you get asked what's duty of candor, and how would you use it in your practice? Do know that as well. Reflective practice, this is massive. So really have those cases, revisit your portfolio, or where you've worked in, or you were in a situation where you really went away, reflected about it. And these are all various different bits that come under reflective practice. And again, please use this when you're preparing, because if they ask you to reflect or ask you about your reflective practice, you can say, well, I tend to think of my reflective practice in terms of my educational appraisal, risk management, my PDPs, various assessment tools such as my MSF tabs, and also the feedback within each of those, and then you can give a bit of a breakdown of relevant bits that you have done. Teamworking, again, have a specific example prepped. So here, obviously, demonstration of a skill, you would use STAR, which is a situation, task, action, and reflection or resolution. So have a good example, of we've all been in situations when things went well with teamwork or didn't go so well with teamwork. So really have that STAR set up and a good reflection on it. And again, have a look at what scores you as an outstanding candidate. So you being, calling for help with appropriate, clear instructions, not just, I wanted to get help, but you turn to a nurse, you delegated, you ask them to call the medical registrar, asking them to then come back to you and let you know when the medical registrar will. So bits like that, closed loop communication. So just think about how you're phrasing that, because I'm sure you did it. It's just about getting that across in a very, very time pressured interview. It's a bit of a skill, so time practice is good. Working under pressure, same idea here. Have a specific example, have a few examples really, really like written out, well prepped, very slick. You can talk about it, you can talk about how you would have improved, what you would have done differently if it happened again. What are your take home sort of learning points? And so again, have a look at what classes you as an outstanding applicant if you follow the rubric. And then this is the final, so this is your global rating based on your interview performance. Again, is there, have a look at it. And finally, so these are already structures that I've touched on. Know your camp, so clinical, academic, management, personal. That is, why you want to do anaesthetics, and so those are motivation type questions. And then STAR is when you're having to give an example and talk through a situation that you were involved in. So situation, task, action, result, and ideally with the results also include a bit of a reflection at the very least to say what were your key take-home messages. Spies, that one probably not quite so relevant, depends. It might be relevant to your clinical scenario station. So just again, bear it in mind, what is the problem, assess, what can you do, what do you need help with, involve other colleagues. So that's always like try, delegate as much as possible to be like, let me make the most of the team I've got around me. And finally, just a bit of general interview advice. So prep with a friend, get buddy up if you can, please. It's just so much nicer. I had a couple of friends I was prepping with, and it was actually quite fun. We enjoyed it. Some people like recording themselves and listening back. I get sort of cringe vibes from that, but you know, if you learn from that, then by all means go ahead. Start by writing out your answers. So like literally write them out, use your structures, format it with STAR, with CAMP, and know your answers. Like know them in a way that you can be very like conversational about it, not in a way that you've memorized and the moment like you go off script, you suddenly like you're having to find your feet. And also if you've sort of memorized, some people find a bit monotonous or robotic. So just really get it very slick, be very conversational, be very approachable, be friendly, be, you know, just be someone that they would like to work with. Get slick. So it is very, very, very time precious. So half an hour will literally feel like you've sat there like 5 minutes. So time yourself, don't waffle on, like kind of like back when you were writing your personal statement, make every word count pretty much. So it's a bit like that. Ask a senior colleague to run a time mock for you. So I had a couple of people who very kindly did that for me, and I found it super, super helpful. Good body language. So again, I tend to flail with my hands really badly, like you probably noticed. Keep looking at your camera. Sit with a good posture, put on like, you know, smart shirt, blouse, whatever, and like sit on your hands. I think that's literally what I did. Otherwise they sort of wander all over the place. And yeah, be enthusiastic and be like, just have this positive energy. Like you've got through to the interview, you just have to give them a reason to give you the job. And yeah, I think that's the end of it. So keep calm, give more propofol, also support the airway because otherwise bad things happen. And thank you. So any questions? I've also popped up the QR code and my email address again if you want to message me directly, and please do fill in the feedback and you will get a PDF printout of these slides.
That was brilliant, Adrian. Thank you so much. I had a couple of questions before. There's quite a few questions actually, but just before I get started on those, I just had a couple of questions myself. I know you picked up on it anyway, but what would you say you most enjoy about this specialty, and maybe a couple of reasons about why you picked it in particular?
Okay, so what I really enjoy is that it's very meticulous. I really like being able to deal with one patient at a time. Now, mind you, I am an ACCS trainee, so weirdly, I've not actually done any of my anaesthetic rotation yet, but the things that I really enjoy about it is being able to be meticulous, having that strong grounding in basic sciences. I really enjoy that. I like it because it makes sense and it works, and it's really quite nice to have that physiology literally at your fingertips, and it works, and you go like, I've given this drug and it's worked. I really like the teaching aspect, the one-on-one learning, and I just really, anaesthetists generally tend to have a very, very positive vibe. Like they're genuinely just like tend to be very nice people to be around. Like they immediately want to teach you, they want to, you know, explain what they're doing to you, they want you to be kind of get involved, and every time I've interacted with anaesthetists, I thought, gosh, it's a very, very supportive environment. Now, what introduced me actually to anaesthetics as a specialty was during my physiology degree, I got involved with one of the Everest studies. So I don't know if you guys remember, but there was a couple of big Everest expeditions that went up 2007, I think, and then 2013, I want to say, and they were doing literally taking blood gas samples on, like, you know, pretty much at the summit of Everest, or just like 100 meters below it, and it was all being run by anaesthetists. So to me at that time, that was just like, wow, this is really cool. And then obviously it's not always about like an Everest study, but it was still that physiology and that research and that side of things like really drew me into it. And then I just spent a lot of time with anaesthetists, and I really liked it.
Well, that's amazing, and that is really interesting about the gases that you're mentioning at the top of Everest. I'm not.
Yeah, look it up.
familiar about
Dr.
that.
Dan Martin, he holds the world record for lowest ever oxygen saturations. This chap, the consultant anaesthetist, was walking around with oxygen stats of 31. I think he made like Guinness World Record. And he was like, fine, because just acclimatized. So yeah, anyway, but I won't
Wow.
labor the point. It was interesting.
That's definitely one to research, and I'll do that definitely. Fine. And would you say, in terms of challenges or positives, would you say about anaesthetics? Is there anything you might? I know you sort of just started the training, but anything just to be aware of in terms of maybe the biggest positives? I know we've touched on, but maybe challenges.
So the challenges is that obviously it can be quite lonely, and it is a very, very steep learning curve. So if you think about it, within 3 months of starting your anaesthetics rotation, so for me that will be obviously next year, you have to become proficient with your skill set, and that's a very, very steep learning curve. So you shouldn't be on call for 3 months, but at 3 months you may well be the anaesthetic SHO on call, and you're having to intubate, and there might be sort of some pretty hefty cases going to theatre. You are carrying that bleep, and that can be very, very daunting. So I would say it might be quite daunting for some people to have to really take a lot of ownership of their own training and their own development, especially with a new curriculum, where it used to be very much like the old curriculum was very much tick box after tick box after tick box, and the Royal College actually went like, hold on, we're like tick boxing loads, but are we actually learning? So that was part of the curriculum change. And now it's actually, if you look at my portfolio, there's like no tick boxes at all. So I'm kind of like just putting stuff into my portfolio and going like, well, I hope that's enough. And no one really knows yet, because we're a bit of a guinea pig here with that. The other thing I would say is that you are having to travel quite far. Sometimes, especially if you're a deanery or sub-deanery like mine, is quite big. So Northeast Yorks, which is where I am, stretches like all the way from Harrogate to Scarborough, down to Hull, Grimsby, Scunthorpe. So massive, massive, massive area sometimes that it can cover. And you sort of have to be prepared to either commute if you want to sort of settle down, or just sort of keep moving around. And bearing in mind that it is like 7 years if you're doing core anaesthetics, or 8 years if you're dual training, it's a lot. You do have to sort of basically make a bit of a sacrifice in terms of, do I keep moving around every time like my placement changes, or do I just say, fine, I'll just settle down here, but then I'm accepting quite a significant commute.
Brilliant, thank you for that. And my last one before I mention the other questions, is there anything that you would say in terms of, I know you've done a lot of things, but in terms of a highlight or something you really valued in terms of not only just putting towards your portfolio, but in terms of personal satisfaction as well, that you really enjoyed in terms of your preparation for anaesthetics, or even in your development towards sort of creating your portfolio towards anaesthetics and developing your interest?
Sure, definitely. So like I mentioned, one of the key points for me was getting involved in my during my BSc with research. So that was, for me, was definitely very, very inspiring at the time. Now later on, as I progressed through medical school and then my foundation training, I'm not going to lie, I think probably COVID ITU was again one of those turning points in a way. I think up until I was redeployed, I was very much like, I'm going to do core anaesthetics, I'm just going to be a pure anaesthetist, and I'll be very happy with that. And then I got redeployed, and it was the best supported I'd ever felt. And this was the last rotation of my F1 year, and I felt for the first time like I had a voice, I could voice my opinion. I could, mind you, as an F1, you walk into COVID ITU and you're looking after, like, I had a bay of 3-4 really poorly patients. I had one patient who literally was in, actually 3 of them were at least in dual organ failure. So I had a chap who was running temperatures of 41. He had obviously COVID, so his lungs were really bad. His kidneys were barely functioning, and then he started getting myocarditis on top of that. So essentially 3 of his organs were not great. I had one chap who was, he started off with COVID, and then his kidneys started going as well. And then a third chap in that base started doing the same again. So it was a very similar pattern over and over again of like lungs, then kidneys, then heart. And to be sort of, to walk into a night shift as an F1 and be like, what am I doing here? And basically be told that, right, well, you know, you're the doctor looking after this bay, where obviously consultants going to come round, they're going to do the ward round. There's 2 ward rounds obviously on ITU anyway. And to be like, okay, well, just, you know, start prepping, and then, and to go through that process of knowing your patients in so much detail, then that when there was a changeover of consultant, you'd be the one presenting to an IT consultant about this patient, that just because you knew about them, because you've been caring so long for them. So I think that was that somehow, as much as it was COVID ITU and it was horrible, and it had awful, obviously it was awful for patients and their families, to me it was just one of those moments where I thought, you know, I'm quite good at this and I quite enjoy doing it, and I think I could do this as sort of longer term.
Thank you so much. That is really interesting, actually. And yeah, like I said, the various things you mentioned there. Just a couple of questions now from the audience, if that's okay.
Yeah.
So we could start. I'll start at the top. So one question: how many exams are in the training pathway, and roughly when are these taken? I know you touched on a couple, didn't you?
Yeah. So pure anesthetics 2. There is FRCA primary, so that stands for a fellow of the Royal College of Anaesthetists. And if you're doing just pure anesthetics, you would usually sit that in your CT 3 years. So that's the last year of the first stage of your training. And then there is the FRCA final, which you would then sit in your ST 5 year. If you're doing ACCS, then obviously you would sit it in the last year of your first stage, which in that case is CT4, you would be sitting your primary. And then your final, I think it was still, well, it would be the equivalent of your ST5 year. So that's if you just do anesthetics, nothing else. If you do want to dual train and do ICM, then you also have the ICM, so the FFICM exam. So that's the equivalent fellow of the College of Intensive Care Medicine exam, and that one you would sit at some point during your registrar year. So that would be like, I want to say ST6, but look at the pathway that I've put up. I think that's in your ST6 year. So 2 if you're doing just anesthetics, and then the ICM 1 if you're doing it adds on to that as a third exam.
Brilliant, thank you so much. And a couple of questions. In terms of, actually, you've already touched on it in portfolios quite a lot. So comparing with peers in core anesthetics versus ACCS, someone mentioned you may have had comparatively less theatre or pure anesthetics time. So how do you or specialist registrars find that helps or hinders you in the competencies that you need to know for anesthetics?
So I'm not sure if I follow this question. So
so the question is, comparing with peers in core anesthetics, yes, versus just ACCS. I think the question is, if you're just doing one of those, I'm not sure which, yeah, you may have had less theatre time in terms of pure anesthetics.
No, that so your pure anesthetics won't change though, because all that, so you're still doing the same. So okay, your anesthetics training won't change. Think about ACCS as there being just a 0 year where you do additional 6 months of emergency medicine and an additional 6 months of acute medicine. So essentially, what happens if you do ACCS is that your CT2 year of ACCS, you join up with the new CT1s of core anaesthetics. So right now, I'm doing medicine this year as an ACCS CT1. Next year, I will be joining up with the new intake of CT1 cohort and coming in and continuing my training with them. So I don't feel that, at least at sort of core training level, so during your stage 1 training, that it would impact your theatre time doing ACCS or core, because you you merge onto the same pathway anyway.
Thank you, Adrian. Thank you so much. Brilliant. I think that's sort of our 1 hour. I think that was really, really useful, and there are more questions, but I mean, do you think in terms of the other questions, whether they email yourself or Mind the Bleep, anything that you prefer, Adrian?
Up to you. If there's a few more, I'm happy to take a few more if you have time. If not, entirely up to you, then more than happy to take emails. So entirely, completely up to you.
Okay, we'll see if we can do a couple more questions then. In terms of differences in training in a DGH versus an inner city hospital, is there anything that you might say differs?
It's difficult for me to comment, because really all I know is DGH world. I haven't been in a city hospital in a long time. So I did my foundation training at a DGH, as well as now I'm Harrogate, which is also quite a small DGH. Differences that you might experience, if you're at an inner city hospital, they might be sort of more specialized. That's typically what you tend to get. Inner city hospitals have those specializations because they have the resources of being in a bigger city. So, for example, in where I am now in Harrogate, you don't have vascular surgery, for example, as a specialty. So anything that comes under vascular, even if it's an emergency, would need to go to Leeds from us. So depending on the DGH, you might just simply not have all of the specialties available, like, you know, anesthetics for vascular wouldn't be an option, just simply because vascular isn't done at like Harrogate. Whereas in inner city hospitals, the case might be that they're actually very, very subspecialized. So your bread and butter stuff you're not seeing as much as, but that's a bit of a conjecture based on what I've heard from other trainees. I cannot, unfortunately, speak of personal experience on that one.
That's perfectly fine. Thank you. I think that was really useful, actually. Another question, does an F3 year count as an employment gap?
No, F3 is absolutely fine, and that's not an employment gap. So F3, if you're locuming, you would basically just have to keep quite strict records of your time spent locuming, and ideally have a senior who can oversee that, you know, you are getting training needs done as well. I would say, like, things like procedures, just make sure that there is someone who can kind of oversee you and then act as your reference as well. It's not an employment gap at all, no. And obviously, if you're then doing something like a JCF, then obviously that is more structured, let's say, than a locum year. But no, absolutely not a gap.
Fine, brilliant. And there was a couple of other questions. Lastly, if someone's had time off work, would that make the application less competitive in terms of the gap? But I would think that they would take that into account, I would assume.
Well, no, I mean, it's basically, it's all about unexplained employment gap. So if you, I don't know, it's quite common that someone's been on, like, for example, maternity leave, and then they just say, I was on maternity leave, and it's like, that's absolutely fine. In terms of making the application less competitive, I don't think that would be, I'm not sure why that would be. I wouldn't think it would be less competitive as a result. Not sure why that would be the case.
Yeah, no, I think, like you said, it's all about the reason, and if something's reasonable, then I would assume that should be okay.
Yeah.
And then the last question.
Carry on, sorry.
No, were you going to say something?
No, just I will say that anaesthetics is quite famously good at sort of making provisions for people who've had again very much reasonable and justifiable employment gaps. They're typically very supportive.
Brilliant, yeah. And lastly, well, so someone asked, would a bachelor's in psychology be considered relevant, do you think?
Yeah, I don't see why not. Again, it used to be, if you look at the old self-score system, it would very much be explicit in terms of, is it a degree relevant? So is it your sort of your typical biochem, biomed, bio sort of, whatever intercalation degrees that you could do, like immunology and genetics and so on. I think, again, because self-scoring doesn't really work like that anymore. It's, an additional degree is an additional degree. Like if you did sort of reason, you got a 2-1 or a first, again, it doesn't really translate into points the same way anymore. But yeah, I would definitely say it's relevant.
Thank you so much. Brilliant. I think that wraps up all the questions. Just a big thank you again for your time, and I think that was a brilliant webinar. You went into a lot of detail, and I mean, I learned a great deal myself also, so thank you again. Any further questions, feel free to, I think, Adrian, you mentioned they can email yourself, or they can message Mind the Bleep. But I think we'll probably end it there. Anything else to add, Adrian?
No, perfect. Thank you so much for having me. And yeah, genuinely feel free to email me with anything and everything. If you want more advice on more resources, let me know. I've got a pretty big folder where I've just got everything that I was doing when I was preparing. So if you'd like access to that, you're welcome to it. And like I said, I'm very, very happy to take any further questions. Please send in the feedback, and I will email the PDF printout of the slides to you if something's gone wrong and you can't get it because I don't know, feedback in my should hopefully. Again, just email me and I'll send them to you. So yeah, thank you for having me.
Brilliant, thank you so much. And yeah, exactly. So please fill in the feedback. You'll get the certificates, etc. Fine. Thank you so much.
Thank you.